Is my financial disclosure. So as you all know that the natural crystalline lens has got a good accommodation, clear vision at all distance, great contrast sensitivity, no rotational asymmetry with a minimal aberration. So my question to you all, can a intraocular lens can do the same job as the natural lens? Still it's a question mark. So when I think we started with the multifocal, which has got a gradual diffractive steps on the intraocular lens and which creates a smooth transition between the focal points. But basically these early multifocals are nothing but it's a bifocals. So they used to have a good distance and a good near vision. People has to change their lifestyle. If they want to see near, they have to get the things near to their eyes, or they really have to change. Because of that one, the newer introduction of trifocal and EDOF lens comes into the market. So now, where is the what are the consideration for mix and match? The patient always should have a very strong desire to spectacle independent. So in my case, I picked the patient between around 35 to 75 years. But very important detailed history has to be taken. What is his jobs, and also what is his hobbies, whether he is a unusual avid reader. But for all these patients, short-term glare and halos also uh, sometimes intolerable. So counseling these patients are very important. Sometimes I feel that for them the best option is monofocal lens because uh, but if you put the monofocal lens, the patient used to come back to me and tell that, sir, I can't see the meter board while driving. So these are the problems can happen even with the multifocal lens. So nowadays most of the patient doesn't want to wear the glasses after the cataract surgery. So this is the lens I started initially. This is a Lisa platform, which is a pupil independent, which has got a diffractive ring until the IOL periphery. Basically it is a distant dominant diffractive lens, multifocal lens, which has got 65% for the far distance and light distribution 35% for the near, and with a pseudo accommodative range up to 4 diopters. So I'll not talk about this lens, just a small video. I just started implanting now. The Zeiss stopped these lenses last year, but fantastic lenses. So this was around almost my 10 years old video. I'm showing you how exactly this mix and match we used to do even that time. So the lens is basically a four haptic lenses. So, I never had any problem with even with the rotational asymmetry. So this is the advantage with these lenses. Basically, it's a light. Why they called Lisa, because of light is distributed asymmetrically, which is independent from the pupil size. The greatest feature of these lenses is with the SMP technology with the aberration correcting optimized aspheric optic. So coming to the EDOF lenses, EDOF lens is basically it is a excellent compromise benefits of both monofocal and multifocal intraocular lens. More spectacle independence compared to the monofocal intraocular lens with a fewer visual side effects compared to the multifocal intraocular lens. So basically this SMP technology is nothing but the smooth microphase technology that reduces the glare and halos. So the lens with the SMP technology normally will have a very less glare and halos. So coming to the advantage of these EDOF lenses from Zeiss is less sensitive even for the decentration and the tilt. So patient never used to give complaint if a slight tilt is there. Basically it's a neutral aspirated design lens, does not interfere with the corneal higher order aberration, and even it was suitable for post classic patient. So also lens will go through around 1.8 mm wood assisted or 2 mm with the regular injecting. The greatest feature what you can see here, even though it's a hydrophilic lens, it has got a 360-degree anti-PCO ring with a sharp edges. So these are the advantage with these lenses. This is the first. I'll not show you much about the similar kind of procedure. Basically, all these lenses, when you're putting multifocal or trifocal, your rexis has to be around 5.5 mm, so that you have to center the lens exactly, which is coincide with the coaxially sighted light reflex. This is very important. Once you do that, I think all the results is going to be ultimate with a very less glare and halos. So always you have to give the patient time about your neural adaptation also. If the neural adaptation process that take place as the brain adapt to change the visual information being supplied by the eye's optical system. So normally want to tell you the visual complaints are not related to the aberration, they are related to the neural adaptation. And the success of a patient outcome continues to improve because of they have adapted to this neural adaptation. So our experience. So it is initially for all these premium lenses, what I do normally, I myself check for the dominant eye and also I check for the which is the non-dominant eye. So once I'm really confirmed, then I ask the patient history with the dense cataract also how he used to use his eyes. For example, whatever his hobbies, how he used to do like shooting test or pointing test. Make sure that which is his dominant eye. So for dominant eye, I put the EDOF lens, and for non-dominant eye, I implanted with the multifocal lens. The inference is more than 90% of the patient at a very good distance and intermediate vision. Non-dominant eye gives you the very good added benefit of intermediate vision, and no, non-dominant eye gives a added benefit of near vision and no glare and halos in any of my patient, and they are very comfortable for night driving. The follow-up is for 6 months is going on, and extremely happy patient. Probably more longer follow-up is required. In conclusion, more than 90% of the patients are satisfied with the EDOF lens, which gives an excellent distance and intermediate vision. Adding multifocal lens to the non-dominant eye, that helps in near vision. So more than 90% of the patients are spectacally independent. Hardly any complaint of glare, halos in any of my our patient. Probably you require a long-term follow-up. So what I just want to tell, I think when you're doing any of the premium lenses, I think you have to check the dominant eye. I think that is the key. I think by putting even rings in the non-dominant eye also, the glare and halos in the eye, that patient will be much lesser. Thank you.